Hello, I am Ann DeMaio. It is a pleasure to speak to you today about cardiac. Let's begin with the objectives. Describe the anatomic and physiologic transition from fetal to neonatal circulation. List the diagnostic tests to be ordered for an infant with a cardiac condition. Describe 3 clinical presentations of cardiac conditions. Explain the nursing care required for an infant with a cardiac condition. Describe post-cardiac surgery nursing care. Identify nursing considerations for the administration of cardiac medications. Physiology. Fetal cardiac development occurs rapidly from 18 days of life until the 12th week of life, with structural formation until the 8th week. The cardiac tube develops from primitive heart structures. It elongates and develops dilatations and contractions that will later form the ventricles and outflow tracts. Abnormal development during this stage can cause corrected transposition and dextrocardia. The atria and ventricular septum form next. Endocardial cushions form the atrioventricular valves. Abnormal development during septation can cause a ventricular septal defect, atrial septal defect, endocardial cushion defect, stenosis, atresia, and absence or deformation of the tricuspid and mitral valves. The great vessels, including the aorta and branches, septum, and semilunar valves, form before the 8th week. Abnormal development during this stage of development can cause truncus arteriosus, tetralogy of Fallot, pulmonary or aortal valve atresia or stenosis, and transposition of great vessels. The umbilical vein carries blood with high oxygen concentrations and nutrients from the placenta to the fetal liver, where half will perfuse the liver and the other half will flow through the ductus venosus to the inferior vena cava, which is also known as the IVC. The high oxygen concentration blood from the IVC mixes with some low oxygen concentration blood that comes from the gastrointestinal tract, liver, and lower extremities. Blood then enters the right atrium. Blood flows from the right to the left atrium, through the foramen valve, and to the left ventricle, and through the ascending aorta to perfuse the head and neck. Fetal brain will receive well-oxygenated blood. The superior vena cava, also known as SVC, returns blood from the head and neck to the right atrium and ventricle and into the pulmonary arteries, where a small amount perfuses the lungs. Pulmonary arterial vasoconstriction and pulmonary vascular resistance are high. Most of the blood is shunted through the ductus arteriosus and into the descending aorta to perfuse the trunk and lower extremities. After perfusing the lower extremities, most blood returns to the placenta through the umbilical arteries to be reoxygenated. A small amount of the low oxygen concentration blood re-enters the ascending vena cava, where it mixes with oxygen-rich blood from the umbilical vein and re-enters circulation. The foramen valve is the opening between the right and left atrium. The ductus arteriosus is the opening between the pulmonary artery and aorta, and the ductus venosus is the opening between the umbilical vein and inferior vena cava. High pulmonary vascular resistance is shown during the resistance during fetal circulation. Also low systemic vascular resistance from the placenta, and high pulmonary vascular resistance and low systemic vascular resistance are the physiologic basis for persistent pulmonary hypertension of the newborn, also known as PPHN, or persistent fetal circulation, PFC. The most significant change in the fetal to neonatal transition is that the lungs, rather than the placenta, become the primary organ of oxygen exchange. When the newborn takes a breath and the umbilical cord is clamped, the transition from fetal to neonatal circulation begins, which causes significant circulatory changes. With the first breath, systemic vascular resistance, also known as SVR, increases dramatically, so there is reduced blood flow through the ductus arteriosus. The blood pressure abruptly rises and the sympathetic nervous system is stimulated. The lungs expand with the first breath, delivering oxygen and carbon dioxide to the alveoli, which causes the pulmonary vessels to dilate. Pulmonary vascular resistance, PVR, resistance in the pulmonary vessels, decreases, letting more blood flow to the lungs. The increased pressure in the left atrium causes the foramen valve to close and neonatal circulation begins. The foramen valve functionally closes when pulmonary vascular resistance decreases and systemic vascular resistance increases on the first day of life. The foramen valve anatomically fuses within the first month of life. An increase in atrial pressure can reopen the shunt until it is fused. The ductus arteriosus closes within 24 to 96 hours due to increased partial pressure of arterial oxygen in the blood. Hypothermia, increased pulmonary vascular resistance, and acidosis can inhibit or delay closure. The ductus venosus constricts within 1 week. Under resistance, low pulmonary vascular resistance, lungs now oxygenate, resistance is low, so blood can flow through. And then there's high systemic vascular resistance. The inferior vena cava and superior vena cava carry unoxygenated blood into the right atrium to the right ventricle. Blood goes from the right ventricle through the pulmonary artery to the lungs where it is oxygenated. The pulmonary veins from the lungs bring blood back to the left atrium, to the left ventricle, and out through the aorta to the body. Cardiac output is the amount of blood the heart pumps in 1 minute. Cardiac output equals the number of times a heart beats per minute, which is the heart rate, multiplied by the stroke volume. Stroke volume is the combination of preload, afterload, and contractility. Preload is the volume of ventricular blood flow before contraction. The heart has spring-like properties. The more it is stretched, the more vigorously it springs back. This effect is known as Frank-Stirling's law of the heart. Filling with more blood enhances the contraction of the heart by stretching it further up to a certain point. As with any other spring, excessive stretching or filling can reduce or destroy the pumping ability of the heart muscle. Afterload is resistance to blood leaving the ventricle. The larger the vessel, the less resistance to blood flow. The smaller the vessel, the more resistance to blood flow. Contractility is the speed of ventricular contraction. Factors influencing blood return to the heart include acidosis, hypoxia, hypovolemia, high ventilator pressures, hyperthermia, and hypercarbia. Monitoring electrocardiograph ECG waveforms. On an ECG printout, each small square represents 0.04 seconds. For every 5 squares, 0.2 seconds. The entire neonatal cycle may last only 0.4 seconds. One entire electrical heart cycle represents each full complex, P, QRS, and T. The P wave begins a cardiac cycle, showing electrical activity as it passes from the sinoatrial, which is the SA node, to the atrioventricular, AV node, a fraction of a second before the atria contract. There is a pause before the QRS complex for the ventricles to fill. The QRS complex represents the impulse from the AV node through the bundle branches to the Purkinje fibers into the cardiac cells. Stimulation of the cardiac cells causes the ventricles to contract. After the QRS, there is a pause, known as the ST segment, which allows the heart to return to normal. The T wave represents the ventricles getting ready for another contraction. There is no physical activity of the ventricles. Placing an electrocardiograph lead. Anatomical landmarks. Choose a location with dry, intact skin for good contact. Place the lead with a white wire on the right side of the chest, the lead with a black wire on the left side of the chest, and the lead with a red or green wire on the left side of the chest just below the rib cage, avoiding bony prominences. The mnemonic to remember lead placement by color is white on right, smoke over fire, meaning that white wire goes on the right side of the chest and black wire goes above the red or green wire. Leads are the angle at which the monitor is looking at the heartbeat. In lead 1, the monitor is looking at the electrical activity coming from the right side toward the left side. In lead 2, the monitor is looking at the electrical activity coming from the right side toward the lower left abdomen. In lead 3, the monitor is looking at the electrical activity coming from the left side toward the abdomen. Troubleshooting. Spikes on the monitor may indicate loose or improper lead placement. Chaotic, jittery movement or wandering line may occur with a restless infant moving around, hiccups, or caregiver patting, burping, or handling the infant. When leads are not picking up, check to see that the lead is securely plugged into the cable, that the lead is placed on the infant, not on the bed, or try a different lead. The gel on leads may be dry. If all measures fail, replace leads that are not coherent. For frequent bradycardia, monitor readings when the infant appears stable to see if all leads are on and in appropriate position. For wave contours, check electrolyte lab values. The most common abnormalities are peaked or flat T wave, widened P wave or QRS complex, and frequent premature ventricular contractions, also known as PVCs. Presentation. Infants with cardiac conditions often have one or more or three categories of symptoms: cyanosis, circulation problems including murmur, pulse, and blood pressure abnormalities, and congestive heart failure symptoms including changes in respiratory pattern, lung pattern, and liver measurements. Physical findings for peripheral and central cyanosis. The difference in peripheral and central cyanosis is indicated by mucous membranes, extremities, perfusion, arterial oxygen saturation, and outcome. Factors that influence degree of visible cyanosis are the amount of total hemoglobin in the blood, amount of hemoglobin bound to oxygen, which is saturation, amount of fetal hemoglobin compared to adult hemoglobin. Depending on the total amount of hemoglobin in the body, cyanosis occurs when at least 5 grams per 100 milliliters of deoxygenated hemoglobin is in circulation. Visible cyanosis is also affected by underlying anemia, polycythemia, and levels of 2,3-diphosphoglycerate. In differentiating cyanosis, peripheral cyanosis is usually indicative of blood shunting to vital organs and away from extremities, caused by autonomic system immaturity, sluggish movement of blood, arterial or venous obstruction, or hypothermia, also normal from birth to 48 hours. On the other hand, central cyanosis is caused by blood leaving the heart unsaturated and always pathologic. Crying. Cardiac etiologies will have increased cyanosis. Pulmonary etiologies will have decreased cyanosis. Respiratory pattern. Cardiac etiologies may have tachypnea or slow, deep respirations. Pulmonary etiologies may have retractions, grunting, and tachypnea. Carbon dioxide level. Cardiac etiologies have a normal or decreased level of carbon dioxide. Pulmonary etiologies may have an increased level of carbon dioxide. Supplemental oxygen. Cardiac etiologies may have minimal response. Pulmonary etiologies are usually responsive. Cardiac exam. Cardiac etiologies may have murmur and weak pulses. Pulmonary etiologies usually have normal exam. Electrocardiograph, also known as ECG. ECG may be abnormal with cardiac etiologies, and ECG is normal with pulmonary etiologies. Echocardiogram shows abnormal findings with cardiac etiologies. Echocardiogram shows normal findings with pulmonary etiologies. Chest X-ray indicates abnormal shape, size, and heart position with cardiac etiologies. Chest X-ray shows lung disease with pulmonary etiologies. In assessing circulation, auscultate heart sounds for 1 full minute. Check the heart rate, rhythm, check for murmurs. Findings associated with cardiac conditions may also include tachycardia, bradycardia, irregular heartbeat, and systolic or diastolic murmur. Palpate all peripheral pulses. Palpate for strength and equality. Findings associated with cardiac conditions may include unequal upper or lower extremity pulses and bounding or weak pulses. Measure blood pressure on each extremity. Record the value in pulse pressure. Measure blood pressure cuff size for accurate reading by using lines on cuff. Take blood pressure during quiet state. Findings associated with cardiac conditions may include hypotension, hypertension, widened pulse pressures, and a wide discrepancy between extremity blood pressures. Assess perfusion. Assess color on head, neck, and mucous membranes. Assess skin temperature and capillary refill. To measure capillary refill, press and release skin on infant's abdomen and count the number of seconds until color returns. Findings associated with cardiac conditions may include pallor, cyanosis, cool extremities, and capillary refill greater than 3 seconds. Heart rate. Normal findings. Heart rate is 100 to 160 beats per minute. Brief fluctuations are normal. Sinus bradycardia less than 80 beats per minute is a common transient finding. Sinus tachycardia greater than 180 to 200 beats per minute is a rise in heart rate with stimulus that resolves quickly. Supraventricular tachycardia, SVT, is indicated by a sustained heart rate greater than 200 beats per minute with no change in heart rate, with activity or crying, abnormal P wave or PR interval. Associations include Wolff-Parkinson-White syndrome, maternal hyperthyroidism, hypoglycemia, or Epstein's anomaly. SVT presents in utero or neonatal period. In utero, SVT can lead to heart failure and high drops. Fetal SVT is treated with maternal ingestion of digoxin, verapamil, propranolol, or procainamide. Neonatal SVT is treated with digoxin or adenosine, cardioversion, transesophageal pacing, diving reflex, covering the face with cold washcloth for 5 seconds. Digoxin is routine for 9 to 12 months after conversion. Normal findings in rhythm would be irregular rhythm. Arrhythmias are not uncommon in neonatal period. For sinus arrhythmia, which is an irregular RR interval, no treatment is necessary. Premature atrial beats are not usually serious and are seen with congenital heart disease, sepsis, hypoxia, maternal caffeine use, and respiratory distress. Premature ventricular beats may be from catheter, surgery, hypoxia, or congenital heart disease. If infrequent, treatment is not necessary, but if persistent, a workup is indicated. Significant rhythm variation. Complete Atrial ventricular block, also known as third-degree heart block, is a complete block of electrical impulses between the atria and ventricles. The atria are stimulated and contracting at their own rate, while the ventricles are contracting at another rate. This can occur after surgery with congenital heart defects, infections, trauma, digoxin toxicity, maternal lupus, heredity, and myocarditis. Cardiac compression may be required to maintain cardiac output. Temporary or permanent pacing is the preferred treatment. Isoprotenolol or atropine may be used. S1 is systole, mitral, and tricuspid valve. S2 is heard best at the base of the heart. S2 comes from the diastole, aortic, and pulmonic valve. S3 is heard at the apex with diastole. S3 may be heard with a patent ductus arteriosus. When there is significant variation of heart sounds, S4 may be heard, meaning decreased muscle compliance. Normal innocent findings in the murmur would be systolic ejection murmur, which is the most common during the first week of life, when blood flow crosses the pulmonary valve. Continuous systolic murmur is heard before the ductus closes. Soft mid-systolic ejection murmur presents 1 to 2 weeks after birth and disappears by 6 months. Significant pathological murmur variation would be when a loud systolic ejection murmur appears within hours of birth and is usually due to aortic or pulmonary stenosis or coarctation of the aorta. A continuous murmur may indicate patent ductus arteriosus. The definition of congestive heart failure, manifestation of an underlying disease, and final compensatory mechanism of the body to oxygenate the organs. Etiology of congestive heart failure: increased volume to heart from fluid overload or fluid retention, obstruction of flow due to structural defects or pulmonary hypertension, ineffective muscle contraction due to electrolyte abnormalities, ischemia or acidosis, dysrhythmias such as atrioventricular block or tachycardia, and increased cardiac output due to demand such as anemia. In the physiology and presentation of congestive heart failure, there is decreased blood pressure, which stimulates the sympathetic nervous system to increase the heart rate, blood pressure, and cardiac muscle contractility. This decreases cardiac output, which causes tachycardia, bounding pulses, and diaphoresis. Catecholamine released from the sympathetic nervous system causes more efficient blood return to the heart and also causes veins to constrict. This decreases circulation to the skin, kidneys, and extremities, which causes poor perfusion, capillary refill greater than 3 seconds, and mottling on extremities. Decreased circulation to kidneys stimulates renin, angiotensin, and aldosterone release, which tells the body to retain sodium and water. This increases blood volume on an already overloaded heart, leading to murmur, bronchi on breath sounds, and fatigue with feeding. The heart muscle thickens to increase the pressure to pump, which is ineffective initially but eventually becomes ischemic, which causes arrhythmias, cardiomegaly. The right ventricle is unable to pump the blood to the lungs, and increased pressure in the right atrium causes systemic circulation to be overloaded. The left ventricle is unable to pump blood into the system, so blood backs up into the lungs, which causes the lungs to become congested, as well as tachypnea, peripheral edema, hepatomegaly, irritability, and metabolic acidosis. You may notice tachycardia bounding pulses, and diaphoresis. This is managed by decreasing stimulation by sedation, providing cluster care, minimizing procedures, administering comfort measures, and administering pain medications. You may notice capillary refill greater than 3 seconds or mottling. This is managed by decreasing oxygen consumption by maintaining neutral thermal environment. You may also notice murmur, rhonchi, and fatigue with feeding, which is managed by restricting fluids and offering tube feedings. You may notice arrhythmias or cardiomegaly. This is managed by administering digoxin and diuretics. And if you notice tachypnea, peripheral edema, hepatomegaly, irritability, or metabolic acidosis, this can be managed by providing supplemental oxygen, correcting acidosis and electrolyte imbalances, and elevating the head of the crib or incubator. Diagnosis. Chest X-ray is indicated for general assessment of heart size and silhouette, determines pulmonary vascular markings, position the infant on a flat surface with the head midline, shoulders level, not rotated, for anterior-posterior view, and cover the infant's gonads, wear a lead apron. Echocardiography, which is also termed echo, is indicated to evaluate heart anatomy and flow, and provide comfort measures to keep the infant calm. Other diagnostic procedures: electrocardiogram, ECG, evaluates arrhythmias and electrical conductivity. Routine continuous monitoring or 12 lead, detailed for dysrhythmias and anomalies. Troubleshoot as needed. Cardiac catheterization measures oxygen saturation and pressure, can be diagnostical, surgical, or palliative. Monitor for bleeding, shock, hypotension, and cardiac tamponade. Dysrhythmias are not uncommon. Conditions. Identifying acyanotic and cyanotic defects is one way to categorize heart defects. Depending on the condition, the infant may not always fit exactly into these categories. Some defects are mixed and may have components of both categories. Most acyanotic defects increase pulmonary blood flow from a left to a right shunt and overload the pulmonary system. Atrial septal defect, also known as ASD, is an opening in the atrial septum. The pathophysiology of atrial septal defect: blood usually shunts from the left atria to the right atria, right ventricle more compliant than the left ventricle. Blood flow can reverse if blood flow into the right ventricle decreases, which then causes possible systolic ejection murmur, which is usually asymptomatic, enlarged heart on the chest X-ray with increased pulmonary vascularity if the infant has congestive heart failure, and the electrocardiograph shows mild right ventricular hypertrophy. We manage this by preventing and treating congestive heart failure symptoms. There is no need to limit activity for children. Surgery for significant shunt may be needed between 2 to 5 years of age. When the ductus arteriosus is patent, blood flows from the left side to the right side, re-enters the pulmonary vessels, and increases pulmonary blood flow. The amount of blood flow through a patent ductus arteriosus and the effects of the blood flow through the ductus depend on the diameter of the ductus and the difference between systemic and pulmonary vascular resistance. A large ductus will cause increased pulmonary blood flow and pulmonary vascular resistance, pulmonary hypertension, and right ventricular hypertrophy. A large ductus will cause increased pulmonary blood flow and pulmonary vascular resistance, which causes pulmonary hypertension and right ventricular hypertrophy, bounding peripheral pulses, hyperactive precordium, murmur, and widened pulse pressures, possible poor weight gain, or frequent respiratory infections in older infants. Signs of congestive heart failure if the infant has a large PDA that's untreated or unresponsive to therapy. Also increased pulmonary vascularity and cardiomegalar on echocardiography and chest X-ray. Sometimes there are no symptoms for a small patent ductus arteriosus. We manage the patent ductus arteriosus by restricting fluids and administering diuretics. Conservative management varies depending on severity of symptoms. Administering indomethacin, which works best for infants less than 2 weeks old and is not effective 4 to 6 weeks after birth. Observe for contraindications to indomethacin, including necrotizing enterocolitis, bleeding disorders, renal failure, low platelet count, and hyperbilirubinemia. Providing preoperative and postoperative nursing care for PDA ligation. Surgical ligation usually is done when indomethacin fails. A ventricular septal defect is an opening in the muscular or membranous ventricular septum. In the pathophysiology, blood is shunted through the VSD, which causes no symptoms, small VSD, or murmur, depending on the degree of shunting. Recurrent pulmonary infection, poor growth, fatigue, and congestive heart failure symptoms in infancy with a large VSD. Cyanosis and pulmonary hypertension with severe VSD, and cardiomegaly on chest X-ray. We manage this by monitoring and treating symptoms of congestive heart failure, administering prophylaxis against bacterial endocarditis, providing preoperative and postoperative nursing care. VSD may have spontaneous closure. Small ventricular septal defects generally close spontaneously by age. Muscular VSDs have a higher spontaneous closure rate than perimembranous VSDs. Surgical care. The surgery timing depends on severity and location of the VSD. Indications for surgery include failure to thrive, significant congestive heart failure, or increasing pulmonary vascular resistance. Asymptomatic moderate VSD is usually corrected between 2 to 4 years of age. Endocardial cushion defect is also called atrioventricular AV canal or atrioventricular septal defect AVSD. Endocardial cushions form a portion of the atrial and ventricular septa and AV valves. A wide range of defects is possible. In the pathophysiology, incomplete fusion of the endocardial cushion during fetal development causes increased pulmonary blood flow from the abnormal connection between the ventricles and the atria, which causes respiratory distress, tachycardia, murmur from increased pulmonary blood flow due to the abnormal connection between both ventricles and the atria or by absent or malformed AV valves. Failure to thrive and congestive heart failure symptoms with progression in infancy, cardiomegaly with increased pulmonary vascularity and prominent main pulmonary artery segment on chest X-ray. prolonged PR interval, right and left atrial enlargement, and right ventricular hypertrophy on echocardiograph. We manage by preventing and treating congestive heart failure with diuretics and digoxin, providing prophylaxis against BE, providing preoperative and postoperative nursing care with palliative or corrective surgery. Pulmonary banding is also a possibility. Corrective surgery is generally indicated when congestive heart failure symptoms are unresponsive and with recurrent pneumonia, failure to thrive, and pulmonary hypertension from large shunt. Repair is usually done between 6 months and 2 years of age. Coarctation of the aorta. Coarctation is a narrowing or constriction of the aorta in the aortic arch segment, most commonly below the origin of the left subclavian artery. Coarctation of the aorta may occur as a primary lesion or secondary to constriction of the ductus arteriosus. Severity depends on location and degree of constriction. Preductal coarctation of the aorta is associated with defects 40% of the time. Postductal coarctation is not usually associated with defects. Collateral circulation is well developed. Aortic constriction in the arch segment obstructs blood flow to the left ventricle and increases pressure, causing the left ventricle to dilate and hypertrophy, elevating upper extremity blood pressure and pulses. Collateral circulation develops around the constriction to compensate the lower extremities and abdomen, which causes absent, weak, or delayed pulses in lower extremities. Congestive heart failure symptoms with hepatomegaly. Enlarged heart with left ventricular hypertrophy and pulmonary vascular congestion on chest X-ray. We manage this by preventing and treating congestive heart failure, administering prostaglandin E1 to maintain ductal patency if the constriction is at a level of ductus, and providing preoperative and postoperative nursing care. Surgical repair by resection of abnormal segment and anastomosis or subclavian patch across the area of obstruction is usually done when the infant is between 3 and 5 years of age, if symptoms are manageable. Most defects are caused by unoxygenated blood shunting into systemic system, right side to left side shunt, bypassing the lungs. We manage the effects of cyanosis, hypoxemia, oxygen, blood gas monitoring, acidosis, polycythemia. Tetralogy of Fallot is characterized by a series of 4 defects: pulmonary stenosis, ventricular septal defect, aorta overriding ventricular septal defect, and right ventricular hypertrophy. The pathophysiology of tetralogy of Fallot. The ventricular septal defect and overriding aorta allow oxygenated and unoxygenated blood to mix. Pulmonary valve stenosis causes the blood to flow through the VSD into the aorta, decreasing blood flow to the lungs, which causes cyanosis, hypoxia, and dyspnea. Symptoms depend on the severity of pulmonary stenosis and size of the ventricular septal defect. Other effects would be a loud murmur, which may be the only symptom, increased blood viscosity, and a boot-shaped heart on X-ray, normal heart size with decreased pulmonary markings. Hypercyanotic or TET spells. These occur when pulmonary vascular resistance rises and systemic vascular resistance falls, which causes blood to bypass the lungs and flow back to the body unoxygenated, right to left shunt. High carbon dioxide and low oxygen levels cause pulmonary vessels to constrict more, leading to increased respiratory rate and depth, hyperpnea, which increases shunting. Increased blood viscosity may lead to stroke. We manage this by keeping the infant calm, preventing and treating hypoxemia, polycythemia, infection, and dehydration, providing preoperative and postoperative nursing care. Correctional surgical repair may be done after 6 months, but delayed until 2 to 4 years for symptom-free children or infants who undergo palliative procedures. In transposition of the great arteries or vessels, TOGA or TOGV, the position of the great arteries is reversed. The pulmonary artery rises from the left ventricle and the aorta rises from the right ventricle. Blood mixing must occur through a patent ductus arteriosus, atrial septal defect, which is ASD, or ventricular septal defect, VSD, for survival, which causes cyanosis in the first 24 hours and becomes progressive, and then an egg-on-side heart appearance on the chest X-ray. We manage this by administering prostaglandin E1 to maintain ductal patency, correcting acidosis, hypoglycemia, and hypocalcemia, administering oxygen, and providing preoperative and postoperative nursing care. TOGV is considered a cardiac surgical emergency. Palliative surgery options include balloon septostomy or pulmonary artery banding. Corrective surgery involves switching to the right and left-sided structures at the ventricular, arterial, or atrial level. In total anomalous pulmonary venous return, TAPVR, the pulmonary veins empty into the right atrium rather than the left atrium from and through a connection with the systemic veins. There is no connection between the pulmonary veins and the left atrium. If there is an atrial septal defect or a patent foramen ovale, some blood can cross into the left atrium and ventricle and into systemic circulation. If there is no obstruction to blood flow, the flow is increased. If there is obstruction to pulmonary blood flow, the flow is decreased, which causes severe cyanosis. In the pathophysiology with no obstruction to pulmonary blood flow, TAPVR causes mild cyanosis, frequent infection and poor growth, congestive heart failure, and a snowman appearance of the heart on the chest X-ray. With obstruction to pulmonary blood flow, TAPVR causes severe cyanosis exacerbated by feeding and respiratory distress in the newborn period. We manage this by preventing congestive heart failure and hypoxemia, administering diuretics for pulmonary edema, and providing preoperative and postoperative nursing care. Cardiac catheterization with balloon atrial septostomy promote better mixing of blood. Surgery is imminent when pulmonary venous obstruction is below the diaphragm. With surgery, the anomalous veins are detached and transplanted to the left atrium. The atrial septal defect is repaired. Hypoplastic left heart, HLH, is characterized by a hypoplastic left ventricle and ascending aorta and atretic or hypoplastic mitral and aortic valves. Blood flow to the descending aorta, aortic arch, and coronary arteries depend on a patent ductus. Blood flow is obstructed through the left side of the heart, which causes tachycardia, tachypnea, dyspnea, and pulmonary rales. Progressive cyanosis, pallor, and mottling when the ductus arteriosus closes. at approximately 1 to 2 days of life, a condition which is asymptomatic at birth. We manage this by preventing hypoxemia and correcting metabolic acidosis, administering prostaglandin E1 to maintain ductal patency, and avoiding supplemental oxygen preoperatively, because oxygen is a potent vasoconstrictor and will stimulate the ductus to close. We also manage by providing preoperative and postoperative nursing care for staged surgical repair, comfort care, and cardiac transplant. In preoperative nursing care, witness or check for consent for surgery and for blood products. Administer nothing by mouth, NPO, for 4 to 6 hours before surgery, varies by institution. Administer IV fluids. Administer antibiotics. Obtain laboratory work as indicated by the condition. Support and keep the parents updated by helping them to connect with the surgeon and anesthesiologist, and advise the parents to arrive early for the surgery and to be available either in person by phone or by phone. Update the parents with progress. Postoperatively, we continuously monitor the heart rate. Use limb leads to show the P wave and the QRS complex. Bradycardia may be due to inoperative cooling, extensive atrial surgery, injury to the sinoatrial node, atrioventricular block, or edema around the conduction system. Tachycardia can be due to hypovolemia, pain, agitation, and fever. When we monitor the respiratory rate, we monitor the ventilator settings and the change in oxygen requirements, and monitor chest tube output. Monitor for decreases in oxygen saturation, which may indicate decreased cardiac output or increased shunting after troubleshooting mechanical ventilation. Slight decreases in oxygen saturation may be the first sign of pulmonary hypertension. Monitor arterial blood pressure with waveform to calculate pulse pressure and titrate drips. Measure upper and lower extremities blood pressures manually after repair of coarctation of the aorta. Avoid manual blood pressure in the extremity where an artery has been used for surgery. Monitor pain and sedation score with vital signs as needed. Pre-medicate before procedures as needed. Urinary output of 1 to 2 mLs per kilo per hour is an indicator of adequate renal perfusion. Monitor for sudden decrease in urine output. Analgesics may cause urinary retention. Right side pressures are useful for monitoring pulmonic stenosis and tetralogy of Fallot. Increasing values are seen with right ventricular overload, pulmonary hypertension, tricuspid regurgitation, and cardiac tamponade. Left-sided pressures are used to monitor for ventricular function and pulmonary shunting. Monitor for bleeding, infection, and electrolyte imbalances. If there is heart failure, monitor for symptoms of congestive heart failure that may be more pronounced. The infant may have weak cry, decreased muscle tone, blue mucous membranes, gray or mottling skin, cool extremities, edema, capillary refill greater than 3 seconds, oliguria, tachycardia, sudden weight gain, respiratory distress, or metabolic acidosis. We manage with transfusion, strict intake and output, corrective measures for acidosis, hyperventilation, cardioversion, and pacing. Monitor the blood pressure and medications. In shock, monitor for inadequate circulating volume, which causes insufficient oxygen and perfusion to the tissues. Causes include hypovolemic, cardiogenic, and septic shock. Symptoms may include tachycardia, bradycardia, tachypnea, poor perfusion, hypotension, decreased urine output, acidosis, hypoglycemia, temperature instability, and coagulopathies. Manage with oxygen, ventilation, and cardioversion. Minimize handling. Correct electrolyte imbalance. Provide neutral thermal environment. Medications include prostaglandin, nitroglycerin, nitroprusside, inhaled nitric oxide, isopril, milrinone, and vasopressors. In respiratory distress, monitor for signs of respiratory distress such as tachypnea, nasal flaring, retractions, grunting, and increasing ventilator support. Manage this with high-frequency ventilation and inhaled nitric oxide. For pulmonary hypertension, monitor for signs of pulmonary hypertension, such as the need for increased oxygen or respiratory support and poor perfusion. Manage this by avoiding hypoxemia and acidosis, hyperoxygenate before procedures, manage pain, and minimize handling. Monitor for bleeding or oozing after procedures or with suctioning. Monitor platelets and coagulation factors. Transfuse with fresh, whole blood. Transfuse platelets and cryoprecipitate. Keep the infant sedated and minimize handling. Monitor for hypotension and fluid overload. Manage with vasodilators. Monitor intake and urine output rates closely. Monitor for low glucose, potassium, and calcium. Monitor for acidosis. Manage by replacing electrolytes to prevent seizures and maintaining slight alkalosis through hyperventilation, sodium bicarbonate, and hyperoxygenation. Monitor for malnutrition. Manage this with total parenteral nutrition. Monitor for agitation and change in pain scale score. Manage with analgesics, frequent assessment, intervention, and reassessment. Provide analgesia with sedation. Medications. Adenosine is contraindicated when there is AV block, atrial flutter, fibrillation, and ventricular tachycardia. Heart block and other arrhythmias are not uncommon during conversion. Monitor ECG continuously during treatment. The infant may need a higher dose if on caffeine or theophylline, lower dose if on digoxin or carbamazepine. Digoxin should be used only if there are clear indications due to its toxic nature and narrow therapeutic range. Monitor for arrhythmias, renal function, and hypokalemia. Store the drug in light-resistant container. Digoxin levels are indicated when there is a suspected toxicity or clinical need to increase the dose. To treat digoxin toxicity, stop administering the drug and administer phenytoin for ventricular arrhythmias, atropine, or insulin. With dobutamine, taper the dose before discontinuing and correct hypovolemia before initiating. Adverse effects of dopamine include hypertension and arrhythmias, not common in doses less than 20 micrograms per kilogram per minute. Administering with phenytoin has led to seizures. Avoid using with dopamine or use carefully. Administer indomethacin slowly to avoid hypotension. With nitroprusside, monitor for cyanide toxicity and methemoglobinemia. Propranolol is contraindicated in hyperactive airway, chronic lung disease, heart block, shock, heart failure, and hypoglycemia. Other adverse effects include hypotension, heart block, asystole, seizures, and elevated triglycerides. Intravenous forms should be used for emergencies only. Use caution when switching from oral to IV. IV dose is 1/10 the oral dose. Alprostadil, signs of improvement are improved blood pressure, pH, urine output, and blood oxygenation. Applications. A previously stable 29-week, 925-gram infant develops tachycardia, widened pulse pressure, bounding pulses, murmur, and inspired oxygen increase. What cardiac condition do you expect? Patent ductus arteriosus. The incidence of patent ductus arteriosus is related to gestational age and birth weight. Because of lower pulmonary vascular resistance, blood shunts from the left side of the heart to the right side of the heart across the ductus and produces an increase in pulmonary blood flow. For which medication will you anticipate an order? Indomethacin inhibits prostaglandins, which dilate the ductus. The second dose of indomethacin is due. During an assessment, you'll find a murmur, bounding pulses, tachycardia, a distended gray abdomen, and urine output of 0.4 milliliters per kilogram per hour. What will you do? Notify the physician or practitioner. The infant has some clinical signs of necrotizing enterocolitis, which is a contraindication for indomethacin. The urine output is also low, and renal function should be evaluated. A 3-day-old infant is diagnosed with tetralogy of Fallot after turning extremely blue and crying in the newborn nursery. He is transferred to the NICU. What part of the body is the most reliable indicator for assessing cyanosis? The mucous membranes, head, or neck area are the most reliable indicators of cyanosis. Color in the periphery, which is the hands or feet, is more susceptible to change due to vasoconstriction, temperature, or pain. Color in central areas, the head, neck, and mucous membranes, is less sensitive to these factors. During a procedure 3 weeks later, the infant becomes agitated and cyanotic, and her breathing is heavy. The cyanosis increases despite comfort measures. What intervention do you anticipate first? Administer morphine. The infant is having a hypercyanotic or TET spell, which occurs when pulmonary vascular resistance rises and systemic vascular resistance falls, which causes blood to bypass the lungs and flow back to the body unoxygenated, right to left shunt. High carbon dioxide and low oxygen levels cause pulmonary vessels to constrict more, leading to increased respiratory rate and depth, which increases shunting. Morphine suppresses the respiratory center and hyperpnea to stop the cycle. If TOF persists without surgery, would you more likely see pulmonary edema or nail clubbing? Persistent hypoxemia will lead to nail clubbing. Hepatomegaly and pulmonary edema are signs of congestive heart failure and are due to left to right shunting. An infant with transposition of the great vessels, TOGV, on prenatal ultrasound is delivering and will be transferred to the NICU. To survive, the infant must have what cardiac condition? Patent ductus arteriosus, or atrial or ventricular septal defect. In transposition of the great arteries or vessels, the position of the great arteries is reversed. The pulmonary artery comes from the left ventricle, and the aorta comes from the right ventricle. Mixing of blood occurs at the level of the ductus arteriosus, as long as patent, or through an atrial or ventricular septal defect, if present. What continuous medication infusion will you have ready? Prostaglandin E1 maintains ductal patency. A cardiac catheterization is scheduled. At what level of the heart will blood mixing occur? Atrium. A balloon is inserted into the heart, and a hole is created between the atria for blood to mix. This is a life-saving, temporizing procedure. The oxygen saturation suddenly drops from 85% and sustains at 70%. What is your initial response? Check the prostaglandin E1 drip for patency. Also, immediately check the patency of the endotracheal tube and suction as needed. An extra IV access is helpful for emergencies. An infant with coarctation of the aorta, COA, with congestive heart failure, CHF, is transported to the NICU for evaluation and testing. On admission, which pharmacological interventions will you anticipate? Diuretics and digoxin are used to manage symptoms of congestive heart failure. Dopamine or dopamine are unlikely to help relieve symptoms beyond the narrowing. Prostaglandin E1 is also used to maintain ductal patency if constriction is at the level of the ductus. On physical exam, how do you expect the upper extremity pulses to differ from the lower extremity pulses? Bounding upper extremity pulses, weak femoral pulses. Coarctation of the aorta causes obstruction to the left ventricular blood flow, which causes an elevated pressure, leading to increased ventricular pressure. The left ventricle becomes hypertrophied and dilated. Collateral circulation develops around the constriction to compensate the lower extremities and abdomen, which causes decreased pulses in lower extremities. The infant has arrhythmias and decreased pulses distal to the puncture site after cardiac catheterization. Which of the two symptoms is more likely to be related to the procedure? Hematomas and bleeding are complications of canalization. Arrhythmias or seizures are not directly related to the procedures unless there is a previous history. As a quick reference tool, or to trigger your memory, this acronym applies to cyanotic defects. Trouble. T. Most cyanotic heart conditions begin with the letter T, such as tetralogy of Fallot, transposition of the great vessels, tricuspid atresia, and total anomalous pulmonary venous return. One additional condition is hypoplastic left heart syndrome. R to L. Most cyanotic lesions have a right to left shunt. O. Cyanotic heart lesions will need oxygen. B. Bluish pallor indicates cyanosis. E. Cyanotic lesions may need prostaglandin E1 to maintain ductal patency.